good place to start is just talking about the eosinophil as a whole, and really what is it? Well, it's a type of white blood cell, and it makes up, in normal circumstances, about somewhere between 1% and 4% of the white blood cells that are just out in the regular blood circulation. It's named an eosinophil because it stains very strongly with a dye called eosin, and in Greek for loving is phil, so eosinophil means a eosin-loving cell, and it has several functions, some that are fairly well defined, some that we still are working on our understanding of, but the two main areas where we recognize that it has a role are in allergy and in fighting off parasitic infections. So you'll see on the left there a little schematic of a eosinophil, and the red staining from that eosin is because there are numerous granules that kind of soak up that particular stain, and you can see those are those red granules in this kind of comic strip characterization of it. There's also a big blue nucleus in there. Now the granules contain numerous chemicals, and the chemicals are really what help the eosinophil to do its jobs, and that includes recruiting other cells into the area where the eosinophils are working. It aids them in killing off certain types of organisms, in particular parasites, and it also contains chemicals that seem to cause allergic type reactions, things like histamine. Here's an actual picture under a microscope of an eosinophil, and there's actually a couple different cells there. The little red round cells are red blood cells. The one with the N above it is called a neutrophil, and then the one with the E above it is the eosinophil. Now, normally you have about 500 of these eosinophils or less in a microliter of blood, a millionth of a liter of blood. And when you see higher numbers, that tends to suggest something else going on. It could be allergies or asthma. It could be some sort of autoimmune disease. It could be a parasite like we talked about. Certain types of malignancies can lead to increased number of eosinophils. And then, of course, the EGIDs, which is what we're here to talk about today. So we know that depending on where you are, where you're looking in the GI tract, the number of eosinophils that you see varies. The highest number tends to be in the duodenum, the first part of the small intestine, where you see on average about 20 eosinophils per high-powered field. The large intestine, or the colon, you see somewhere between 10 and 20 under normal circumstances. In the stomach, you see about 10 per high-powered field. And what's interesting, particularly to me, is that in the esophagus, you generally don't see any eosinophils. So that's the one area of the GI tract where seeing eosinophils for any reason implies something is going on there, something that's not a normal situation. And when you have a higher than expected number of eosinophils in any of those areas, and you combine that with the presence of GI symptoms of some sort, you have to at least start to suspect that perhaps an EGID, an eosinophilic gastrointestinal disorder, is present. So the EGIDs in general, they involve some form of GI symptoms typically. And that can be any number of things, from vomiting and abdominal pain, diarrhea, reflux symptoms, even GI bleeding or loss of nutrition or nutrients and malabsorption. And then you have to combine that with the presence of increased numbers of eosinophils somewhere in the GI tract before you would make a diagnosis of an EGID. I'm going to break down the EGIDs into kind of four main categories for the purpose of this talk. There's Eosinophilic Esophagitis, that people will call EE or EoE sometimes. There's Eosinophilic Gastroenteritis, which people will sometimes call EG or sometimes EOG. Eosinophilic Colitis, or EC, and Eosinophilic Proctitis, or EP, which gets talked about a lot less, and I'm just going to talk briefly about that one little aspect as well. Starting with eosinophilic esophagitis, it's characterized by increased eosinophils in the esophagus, and really only in the esophagus. And again, there's no hard and fast rule with how many eosinophils have to be there before you would give somebody the diagnosis, but as a general guideline, people really start thinking about that problem at about 15 in a high-powered field. Some people use 20 as their cutoff, some people use 24. EE can occur in people of all ages. It does tend to occur more often in boys or men than girls and women, really by about 2.5 sometimes up to 3-to-1 ratio. So about 70% of the patients involved are boys, but we certainly see it in girls as well. The symptoms vary a little bit by age. Infants and younger kids, so toddlers, tend to have more reflux symptoms and some irritability and vomiting. As these kids get older, they may complain more often of abdominal pain as a component of that. Might just be that they're able to complain of abdominal pain as they get older, as opposed to an infant or toddler who may not be able to verbalize it. They also tend to have ongoing reflux symptoms and vomiting as well. And then as you get into adolescence and then into adulthood, the complaint that you hear more often are things like difficulty swallowing, something we call dysphagia, the feeling that something is getting stuck on the way down, or actually sometimes people do have something physically get stuck called a food impaction, where it doesn't go down and sometimes even needs to be removed endoscopically. Any of these symptoms can occur in any of the age groups, but generally, as people get older, the symptoms that they complain of do change a little bit. So how do you make a diagnosis of EE or EoE? Well, first you have to suspect the disease, and sometimes that's the biggest hurdle, because if you have somebody who is really unaware of the disease or really isn't familiar with it, that may not be something that's on their radar, so to speak. It may not be something that they're really thinking about. So, a typical case that we might see would be somebody who has a child who has reflux symptoms that are just ongoing, and you put them on medicine that works in the vast majority of kids with reflux symptoms, but they continue to have symptoms just as bad or only maybe just slightly better. And so when I'm faced with that situation, one of the first things I think about is, all right, well, what else is going on? If this isn't following the course that I expect it to follow, is there something that I haven't considered yet that's going on? And EE, of course, for me, comes to mind very early because it's something that I think about every single day. But you have to have that suspicion. You have to have an index of suspicion about the disease in order to make the diagnosis. But then you also need a second step, which is you need to have some sort of confirmation of your suspicions. And the only test that really can confirm eosinophilic esophagitis as a diagnosis is an endoscopy with a biopsy. And as I mentioned on the slide previous, you need to see an increased number of eosinophils in the esophagus in order to confirm the diagnosis. And when we're doing those biopsies, we're very often biopsying the stomach and the small intestine as well. And that's partially because we want to exclude eosinophilic gastroenteritis or some other cause of eosinophilia, because, as I mentioned earlier, eosinophilic esophagitis really affects only the esophagus. You shouldn't find higher numbers of eosinophils in the other parts of the upper GI tract. So what causes EE? Well, EE is primarily thought of as an allergic problem. Foods seem to be the major allergen that cause the problem, although not exclusively. And we are learning that there are other environmental allergens that also seem to play a role. And in some people, other allergens seem to play a bigger role than other people. But if you wanted to characterize the majority of cases are due to allergies, and in particular, food allergies. Treatment is really based on trying to either eliminate what is causing the allergic response or using medications to try to blunt the allergic response. So because a majority of people with EE have food allergies, eliminating foods that they react to is usually a successful way of treating the problem. Now, the problem with that is, of course, identifying the right foods and trying to limit it only to the foods that they're reacting to, because if somebody who reacts to numerous foods, 15, 20, 30, may not have very much left that they can eat, and then that sometimes requires special formulas and things like that. Steroids work very well for EE, and you can use them in different preparations. You can take something called prednisone, or a medicine like prednisone, where you take a pill, you swallow it, it gets absorbed into your bloodstream, and it works on your immune system throughout your entire body, and that does work very well. It does usually involve some side effects if you're on it too long, especially at the higher doses, and you do tend to have recurrence of symptoms after a time after you come off of the medications. There are also localized therapies where you can try to get the medicine to work right on the esophagus. So you take preparations of the medication that seem to stick mostly to the esophagus. They don't really get into the bloodstream to cause some of the side effects that the systemic steroids like prednisone can cause. And those also tend to work quite well. They also tend to result in some recurrence of symptoms if you stop the medications. And then the newest and maybe most exciting aspect of treatment that's come out lately are what's called the biologic therapies. Biologic therapies basically pinpoint a part of the immune system and try to modify it. And one of the ways they do that is with an antibody. So they've created an antibody against something called interleukin 5 or IL-5. And that's basically an important messenger that cells in the body use to talk to other cells and recruit other eosinophils and tell eosinophils to kind of come and get active in the area. And so if you use an antibody to bind up that interleukin 5, then theoretically you can also reduce the inflammation and the number of eosinophils that are recruited into the tissue. Now let's contrast eosinophilic gastroenteritis with eosinophilic esophagitis. It's also characterized by increased number of eosinophils in the GI tract, but it can be really anywhere in the GI tract, from the very top to the very bottom. Most commonly it involves the stomach and the first part of the small intestine, but it really can be anywhere. One of the differences between this and EE is that there's less definitive numbers in terms of making a diagnosis. So, people like to throw out 15 or 20 eosinophils per high power field for eosinophilic esophagitis. It's much more difficult to do that with EG because there's already going to be a number of eosinophils that are there to begin with. And so if there's really, really high numbers, it makes it a little bit easier. If there's kind of moderately high numbers, it makes it a little bit more difficult to make that diagnosis. EG can affect all age groups, but it does tend to be much less common of a disease than EE. And just from personal experience, we will diagnose several people every month with EE. We diagnose maybe one person a year with EG in our practice. Symptoms of EG vary a little bit depending on what part of the GI tract is most affected. So if you have disease in your upper GI tract, then it might present very similarly to EE, things like vomiting or abdominal pain. If it's primarily in the small intestine, it may not cause vomiting. It might cause problems with diarrhea or poor growth or malabsorption of nutrients, loss of protein through the gut, things like that. Disease in the colon tends to present more with diarrhea, sometimes blood in the stool, and then depending on what layer of the bowel is affected, symptoms may change as well. So if you have disease that affects mainly the muscular layers as opposed to the surface layers, you may have more symptoms of blockage or obstruction than if it's just involving the surface. And sometimes you can have EG that affects all the way through all the surfaces of the bowel and can even cause an accumulation of fluid in the abdominal cavity as well. So it just changes and is different depending on the individual patient and what type of disease they have. Diagnosis, a little bit more difficult to make than EE because the symptoms tend to be a little bit more variable. The symptoms that do cause EG or are associated with EG tend to be a little bit less specific. They can be caused in a lot of other problems as well. And then sampling the GI tract in all of the areas of the GI tract is difficult. It's very easy to get a biopsy of the esophagus because we can do an upper endoscopy. It's relatively easy to get a biopsy of the stomach and the small intestine with the same procedure, and it's relatively easy to get a biopsy of the large intestine with a colonoscopy. But you have about 15 or 20 feet of residual small intestine between those two areas that you can reach with the colonoscopy and the upper endoscopy. That's much more difficult to sample. They do make certain types of scopes that can get there, but that's a much more drawn-out procedure. And I'm going to show you another way that you can kind of look at the small bowel as well. The other thing that's important is that, as I mentioned in an earlier slide, eosinophils tend to be present in most places in the GI tract already. So it's a little bit more difficult to know whether their eosinophils there are pathologic or abnormal, causing disease, or are they the normal component of eosinophils that are there to begin with. What causes EG? Well, there's an allergic component to it, but maybe not as much as with EE. We commonly see other allergic disorders in people with EG, so things like asthma and eczema, allergic rhinitis we see in people who have EG in increased numbers. But we do know that people with EG are less likely to respond to dietary elimination than people with EE. That doesn't mean none of them do, but a lower proportion of them do. So that, to me, implies that it's not just strict food allergy or just not strict allergy in general, but that there's kind of multiple factors that come into play, and one of those is probably some problem with the immune system itself, a dysregulation of the immune system itself. Treatment, in general, I usually recommend trying dietary therapy first, just because if it works, that's certainly a great advantage in my opinion. But I also go into it knowing that there's a chance that it's not going to work, and then there are some backup plans that you have to have in place. Steroids do tend to work well with this disorder as well. Sometimes you need to use steroids like prednisone, more systemic steroids, because it's hard to get the steroids to stick to the GI tract all the way from the top to the bottom, so you don't have that same advantage that you have in EE, where it's a limited amount of the GI tract that's involved. There are some other medications, something called gastrochrome, Singulair, which a lot of people are on for a number of other allergic disorders, may be effective in EG. Those don't tend to work very well with EE. And then there are immune modulating drugs, so drugs that we use for people with all sorts of immune problems, in particular things like Crohn's disease and ulcerative colitis. These drugs also may have a role in eosinophilic gastroenteritis as well. Eosinophilic colitis you can think of almost as just a subset of eosinophilic gastroenteritis. It's basically EG that involves only the colon. And the symptoms that you get when you have EC are similar to the symptoms that you'd have if you had Crohn's colitis, infectious colitis, like you had an infection with salmonella, or ulcerative colitis. So basically, they behave similarly. It's important to try to differentiate this from those causes as well. And sometimes we even see increased number of eosinophils with other causes of colitis. So people who have inflammatory bowel disease, Crohn's disease, or ulcerative colitis may have higher numbers of eosinophils in their colon as well. So it sometimes makes it a little more difficult to nail down the diagnosis of one versus the other in the beginning. Treatment, it may respond to dietary therapy, and again, I think it's reasonable to give a try of dietary therapy for these patients. You also may be able to get away with what we consider topical therapy for the colon, same type of things we would use for people who have ulcerative colitis or Crohn's disease, in particular a product called mesalamine. It tends to respond very well to steroids, and again, the immune modulators, just like in other forms of eosinophilic gastroenteritis, may have a role as well. And then lastly, there's eosinophilic proctitis. Eosinophilic proctitis is an allergic problem, and it's usually seen in infants. It usually involves the very most distal portion, the very last portion of the colon, called the rectosigmoid region. Usually is associated with blood and mucus in the stool, diarrhea sometimes, straining sometimes, but it differs from eosinophilic colitis as a whole in that it usually occurs only in infants, and it usually is caused by food allergy, in particular things that are in their formulas like milk or soy proteins. So in summary, the EGIDs, they do share many features, including the important one, which is eosinophilic infiltration of the GI tract. You need a biopsy to confirm the diagnosis pretty much in any of those. They all have some form of GI symptom associated with them, and they all tend to have at least some allergic component, some more than others. There are also several important distinctions, and that includes the EE only occurring in the esophagus, EC occurring as a subset of EG, and eosinophilic proctitis occurring in infants and usually being food allergy related. The last slide here is just kind of a table just to kind of go over everything that we talked about, some of the similarities and differences between all these disorders.